What up, all my two doctors and doctresses? Welcome to another video at the Tooth Factory. Today we're going to discuss antibiotic prophylaxis in the Dental Pharmacology Series, Episode 4. So what's the concept? Well, the American Heart Association guidelines for the prevention of the infective endocarditis by Streptococcus viridans was given out initially in 2007, but we realized it's recently updated in the month of May 2021. It is created to protect the cardiac patients undergoing invasive procedures, including procedures in dentistry. We do invasive procedures, such as the ones that manipulate gingiva. So, in overall basis, the guidelines are divided into two aspects, and it's very crucial that both of these aspects are met before we can provide the antibiotic regimen to the patient. What's the first aspect? It's the underlying cardiac conditions. So we'll look at them in a second. The dental procedures, they must be manipulative to the gingiva. So there's a certain list of those dental procedures which must qualify the patient for antibiotic prophylactic regimen. So what are the underlying cardiac conditions? Well, according to the article, and this is a screenshot from the article directly, the prosthetic cardiac valve or material. So if there's a presence of cardiac prosthetic valve, if there's a transcatheter implantation of the prosthetic valve, cardiac valve repair with devices, such as rings and clips and so on, the left ventricular assist device, or implantable heart. All of these qualify as the cardiac condition for antibiotic prophylaxis. If there is a previous relapse or a recurrent infective endocarditis, so these two conditions right here, they qualify as the antibiotic prophylactic regimen. Then there's congestive heart disease. Now remember, the congestive heart disease, there's so many of them, and specifically the cyanotic ones. There's an entire list of them, but for antibiotic prophylactic purposes, we have narrowed it down into this acronym 5TPE. So they are tetralogy of Fallot, total anomalous pulmonary venous return, transposition of the great arteries, truncus arteriosus, tricuspid valve abnormality, pulmonary atresia, and Epstein's anomaly. I know these are very long and overlapping words, but hopefully 5TPE really helps us. But specifically for those conditions, the unrepaired cyanotic congenital congestive heart diseases should be present, including palliative shunts or conduits, in the process of repairing those. Then if they're completely repaired, but with prosthetic material or devices, whether placed by surgery or if it's placed by transcatheter, it doesn't matter, but they must be during the first 6 months after the procedure. So if the questions ever ask you in the exams that one of these conditions was repaired completely using prosthetic material, but it's been 8 months, then that patient does not qualify for the underlying cardiac condition section. Moving on, repaired cardiac conditions with residual defects, so if there's any defects left, and any surgical or transcatheter pulmonary artery valve placed. Then cardiac transplant recipients who then develop valvulopathy. So if there's a person who received a new heart in transplantation and then they're going through any valve diseases, then they qualify for this. Now, the article from the American Heart Association also includes the antibiotic prophylaxis for dental procedures which are not suggested. So these are the conditions from this list that do not need antibiotic prophylaxis, such as implantable electronic devices such as pacemakers. You don't need antibiotic prophylactic for those patients. Or for example, if there is plugits or vena cava filters or coronary artery stents and so on, if there's any vascular grafts or patches, basically they've specified what you don't need antibiotic prophylaxis for. So that was the underlying conditions, but along with that, our second condition, the dental procedure specifically for this program, should be active. So the antibiotic prophylactic guidelines suggest that all dental procedures that involve the manipulation of gingival tissue or periapical region of teeth or perforation of oral mucosa. Now this can include a lot, for example, scaling and root planing, orthodontic band placements, flap procedures, extractions and exodontia, periapical root canal treatment, subgingival medication placement, biopsy, suture procedure, and anesthetic injections through infected tissue. That's important because the guidelines suggest that you don't need antibiotic prophylaxis for anesthetic injections through non-infected tissue. You don't need antibiotic prophylaxis for that. Taking dental radiographs, you don't need it. Placement of removable prosthodontic or orthodontic appliances, you do not need them. Adjustments of orthodontic appliances and placement of the brackets, you don't need them. But remember, for band, you do. So that's a very minute error that we can make during our examinations, that band and brackets. For band, we need. For brackets, we don't need. Shedding of primary teeth or bleeding from trauma to the lips and oral mucosa, you do not need antibiotic prophylaxis. Now, which antibiotics in which order do we need them? So first of all, let's consider the situation, then we'll look at the agent and then the dose. So situation-wise, let's say you're taking oral. Then first we start with amoxicillin at 2 grams for adults and 50 milligram per kilogram for children. Say you're unable to take oral medication and you have to take intramuscular or intravenous, then we move on to ampicillin. Now remember, these first line drugs are from penicillin groups. Our previous videos are on there, the links are above. And they're also 2 grams, 2 grams intramuscular or intravenous. In children, it's 50 milligrams per kilogram, IM or IV. And say, for example, if we cannot take penicillins, then we move on to cefazolins or ceftriaxone, also not oral. It is 1 gram IM or IV for the cephalosporin group. But in the children's section, it's still 50 milligrams per kilogram IM or IV. So keep that in mind, that in adults it changes, in children it doesn't. Now consider that the patient is allergic to penicillin or the ampicillin and still have to take oral medications. Then we can take cephalexin, 2 grams for adults and 50 milligrams per kilogram for children. Now you must be confused because if we're allergic to penicillin, then how can we take cephalexin, right? Well, let's move on to the asterisk down here. It says, or the first or second generation oral cephalosporins in equivalent adult and pediatric doses. Cephalosporins should not be used in an individual with a history of anaphylaxis, angioedema, or urticarial with penicillin or ampicillin. So this is saying only if you have, for example, type 1 hypersensitivity reactions, then we cannot use cephalexin. We move on to azithromycin or clarithromycin. Again, this is oral if allergic to penicillin or ampicillin. The macrolide group right here has a much reduced dose. For adults, it's 500 milligrams, and for children, it's 15 milligrams per kilogram. And here's the major one. They have added doxycycline as the next line of drugs. This never existed. This was once clindamycin, but in the month of May 2021, the American Heart Association released this article that has no clindamycin anymore. Clindamycin is no longer recommended for antibiotic prophylaxis for dental procedures. Doxycycline is the new next line drug at 100 milligrams for adults and 2.2 milligrams per kilograms for kids who are less than 45 kilograms in weight. And kids who are more than 45 kilograms in weight, we can give them the same dose as adults, which is 100 milligrams. If the individual is allergic to penicillin or ampicillin and is unable to take oral medication, then we can give them cefazolin or ceftriaxone IM or IV. But remember, if they experience a history of anaphylaxis with penicillin or ampicillin, we cannot give them this medication. Also, the dose is 1 gram IM IV, just like before. And for kids, it's 50 milligrams per kilogram IM or IV. So in summary, basically, this slide has important points that says doxycycline has now replaced clindamycin due to the high risk of Clostridium difficile, C. diff infection derived from the clindamycin use. So that's the big update we need to keep in mind. And doxycycline is now used as a third-line agent for antibiotic prophylaxis, where first line is penicillin or cephalosporin groups, second line is the macrolide group, and the third line is the updated doxycycline group. The resource for this lecture was derived from a circulation that was given from the American Heart Association scientific statement titled Prevention of Viridans Group Streptococcal Infective Endocarditis. The link to this article is in the description box below for your further information. Thank you for watching, and stay tuned for more lectures on pharmacology and many more subjects.